let me ask you, you were probably the first who teach us the subtract recombinations, which is the ultimate approach to it. Are you saying now that this new technique will probably be more precise and more effective, and you should insist to do VT mapping during the arrhythmia, even using more dynamic supporters?
Yeah, thank you, David. Now let's frame it historically. We started promoting late potential abolition during sinus rhythm, as it could be performed during sinus rhythm, as the evidence was stemming from surgical studies. We have done we have very many surgeries proving that really late activity was leading to reentry, and taking out the endocardium was abolishing late activity and reentry. Second, it was kind of an honest technique. I like to stress it, because either you have your late potentials abolished, yes or not. You cannot cheat with that. You can have your map that really proves that you have gone to the endpoint, yes or not. So we loved it. Other colleagues have done some remarkable works on it, and needless to say is to quote the work of Pierre Jaïs on the lavas, where the perception, however, of how really you are validating abolition of lavas is a little bit more prone to subjective interpretation, so less clear. Now, all of this work, but not always. Not always. And again, I'm offering here the fact that we thought that we had truths by doing our pentarray or our multi-actor mapping with the cart or with the Navex. Now that we see a tenfold higher number of electrograms, that we see propagation, we have to admit that if we look at the same thing with a different view, and we are really able to understand what happens during sinus and during VT, things are not that easy. I think that we have kind of followed an oversimplified model, which is good, of course. It helped us in very many procedures, but still there are failures. And I think that this is what happens. Ultimately, I think that, at least personally, I think that the concept of really trying to see whether it is the area of block that causes the reentry and how you can prove that you get rid of that is a big challenge. Maybe it might lead us a step forward in the future. Maybe in 5 years we all would work like this. But I think that we cannot obscure ourselves from what we see.
In the first VT case, when you saw the protected disc, so on the line that is creating the functional block, there is fragmented continuous electrocardiogram. Now, we are used to, whenever we see that, to ablate on areas of slow conduction fractionated. But I wonder what you think. I mean, actually, maybe you should not ablate there. I mean, that is the functional block that you're actually making it even worse. So I wonder what your thoughts are about how do you resolve the conflict between a signal that is calling you burn here, and the map that is showing you don't burn here.
Yeah, I agree. Now if I go into that, I understand that the guidance of the signals that tells you kill me is wrong. For example, in that patient, the first one that I showed you, the electrograms recorded all along the line of block, both during VT and sinus rhythm, might be the ones that would call you, but they would exactly meaningless in the ablation reentry, in the ablation of the reentry circuit. You just would only reinforce the barrier of block. So that is why I think that, at least I personally, call into criticism an ablation driven only by the appearance of the electrograms, because you might really get wrong. I think that probably if you see something like that, you still have to see other areas that are critical to the maintenance of the reentry. So if you are telling me those areas on the line of block ABC were really nice, juicy electrograms, to drive the ablation. But actually the ablation was done at a different site that actually caused VT termination. So again, I'm not doing...
Did you ablate on the AV lines or not?
No, I ablated on on the entry, and that fortuitously terminated the VT. Why did I ablate on the re-entry? That was one of our first cases because I liked the electrogram. Then when I reviewed the map, I said that it was really luck, because really, I had no idea at the time that I was really hitting the right spot. And yeah, I think that it is complex because I'm providing you an experience, and during this time frame we did these VTs with arrhythmia, but we did 10 times many more with the other systems. So again, it's a transitional phase for us. Of course now I think that if we were able to get activation maps of all the VTs and all the substrate, we might do much better procedures.
Paolo, one question, two questions actually. One of them is system, it's more general question on the arrhythmia system. Seems to be very dependent on the technical skills of the technician, and also understand that the analysis here is very time consuming. Some of these analyses must have been retrospective analysis rather than real time. And the other question is about you, in the arrhythmia you rely on automatic rejection of points and automatic acquisition by the system, that you cannot actually go back and review. Does it ever happen that it takes you to a totally different place, which is wrong?
Thank you, Michael. I think that yes, the tracing that I try to offer to you are at the best of our experience. It takes an average of 3 days to Nicola, the one that I acknowledged, to really make reassignations. So it really is a time consuming, and actually we are in the process of working together with the arrhythmia engineers to get better and more timely evaluations. The rejection rate of electrograms is a little bit higher to what has been reported in the first paper published on the animal. The rejection is about 20%, and it takes a lot of time. So if you were to me, if you are asking to me, you have a VT case, how do you decide that you do with arrhythmia or with a CART or with a NAVEX? I tell you, it really is on the fact that I think that I have time and energy to spend in this case to learn something. Did I answer correctly to your question? And maybe, of course, if you think that how were we 20 years ago, maybe if we start studying and getting observation on this, maybe in a few years we will get many more experiences.
Well, how about the question about system errors?
System errors leading us to make a wrong ablation never occurred, actually. But again, there is a very strong supervision by myself for the time being. The only one that does ablation with arrhythmia in our center is me. So I always keep an eye to what the system tells me and what the electrograms tell me. So for the time being, it's conceptually hybrid, and then I take days to review what I have been doing based on the actual reannotations.
A little about your strategy. How many non-clinical VTs did you see, and if it was related to the same area of slow conduction, despite being non-clinical? Number one, and number two, a lot of well-tolerated VTs, once you put in the general anesthesia, they become completely intolerable. So how did you manage? Did you do it on the general anesthesia as a general procedure, or you just try to do it locally?
So let's start from the second one, which is the general frame. I do by default all the VT procedures in GA because they are long, because the patient risks to be shocked, so I don't want him, her to suffer from that. That goes along and brings about, as you currently underline, the fact that many VTs that might be actually tolerated when the patient is awake are not tolerated during GA. And that is also the cause for our preference to do subset during sinus rhythm to reduce the risk for VT induction and non-tolerability issues. When the patient really is requiring VT activation because either she failed a subset procedure or because such in patients with IDCM, we do not expect suitable targets during sinus rhythm, and they have untolerated VTs, then we count them on ECMO, preemptive ECMO, to have the VT tolerated. Second, I go back to the first question, untolerated VTs, it's the rule to have countless VTs induced during and before an ablation run. You start with 1 or 2 clinical and you end up with at least 6, 7, 8 non-clinical induced, but they all always, as a golden rule, they are always related to abnormal areas during sinus rhythm that you might have overlooked during an ablation. Is it?
You can go after them?
Yes, always. We try, but not always succeed. We try to achieve complete non-inducibility, and our protocol calls for 4 extras, right and left multiple sites around the infarct. So we try to get them non-inducible at day 0. Now, again, as we were discussing with Michael a few days ago, we started, and now it has become fully operational, the NIPS program at our institution. We call it non-invasive program stimulation, that is performed 5 days later in a completely awake state. Bad news is that about 30%, 27 to be honest, 27% of those patients that are non-inducible at day 0 become inducible to same or similar VTs at day 5 when they are awake. And also to non-clinical, so-called non-documented VTs beforehand. And this finding has prognostic implications, as the recurrence rate is very high. So we have a 6% recurrence rate in patients that have a negative NIPS, which is big reasons of being proud of our institution, and about a 40% recurrence rate of those that are inducible. So this now is leading us to the attitude of offering a second procedure within 2 months in those patients that are inducible to NIPS after the first seemingly successful procedure.
One short question. These days when most of our patients with VTs have ICDs, the issue of clinical arrhythmia ECG is not visible. So would you recommend to insist and let's say put patient in the ICU, stop the ICD, and then try to get clinical arrhythmia, let's say, for frequent VTs, or we say, okay, good enough, I don't need clinical ECG, I will be okay with induction?
No, I think that the issue of clinical VTs is very important. As a matter of fact, very many of our patients tend to have a very long hospital stay. Some of them because we try to make the procedure of amio, and they feel that the last days of amio are the most dangerous. And actually, the highest yield of 12 lead electrons of VT are the ones that are gathered in patients that are spending a few days before the ablation of amio. And we have in our arrhythmia unit, which is big one, we have 34 bed, 12 lead electrocardiographic telemetry and bedside monitoring to increase the yield of VT. And that was true also for those patients that have, after a seemingly successful procedure, after procedure monitoring of their rhythm to get their 12 lead.
Okay, thank you very much, Paolo. That was very
Thank you. Thank you.
interesting. We now have